And of course, as you know, these disorders are quite many. So we are going to move a little bit faster, and I hope that the moderator can take note of some of the questions, because it might be something really extensive to do all this at once. I don't know if I'm still being heard or if my slides are being seen. Please let me know.
You are very loud and clear, and the slides can be seen.
Okay, so I hope I can get started now. Dr. Arinda, okay. Right, so
Doctor, you can start.
I'm going to take you through, okay, thank you so much. I'm going I'll talk about alcohol use disorders. Talk about other subjects. We have been losing people due to pethidine overdose. Last year we lost an SHO. There is a lot of use of nicotine, normally people smoking, tobacco. Cannabis, you guys have heard of these so-called weed cookies, benzodiazepines, amphetamines, you know. When I talk about opiates, of course, you know, heroin is also commonly abused. You've heard of brown sugar, you've heard of speed, these amphetamines, you've heard of tramadol, which is an opioid. Some of them, but I'll focus on alcohol use because it's, I think, the most commonly abused. And then others, I'll give you some details to read about them because the work is quite much, okay? Yeah, so about me, I think I've already been well introduced by my former student, who is now a doctor and moderating this session. That is a doctor. I'm a clinical pharmacist, and I'm currently a PhD scholar. I'm a researcher, and a member of the PSC Education Committee, participated, and the recently published National Antimicrobial Stewardship Manual. I've also participated, and my research currently that I'm doing is about antimicrobial stewardship in the ICU. And I was also lucky to be the pharmacist of the year, 2024. So, of course, PSC has given me several accolades, best academia, and even just last year. So I'm going to start this by sharing a case scenario, which I hope that by the end of this discussion, we could be able to discuss and see what we think about it. Remember, we have majorly 1 hour to discuss, to have this webinar. So I would like us to listen in, and those who are interested, please take notes so that we can be able to discuss these things, okay? So, Dr. Arinda, are you on?
Yes, doctor, I'm on.
This case scenario, which I'll please go first through it. Then we shall discuss it later. Please.
Okay, a case scenario. A 35-year-old female brought with disorganized behavior, disorganized speech, can't see and hear voices of unseen things, poor sleep and poor appetite, long standing for 4 years. The patient also have been taking alcohol of all types for 15 years. No substance abuse. She also undresses, tears clothes, and also runs away with claim that people want to cut her. And she would run to her late auntie's grave claiming that should see her and she was attempting to kill her. In addition to that, she attempted to kill her 4-year-old daughter, claiming that she has red eyes and she she was sacrificed to the underground spirits. Her speech is also disorganized and she's very aggressive. 3 days ago, that is 48 hours after her last drink of alcohol due to lack of access, she got symptoms of agitation, acute mental confusion, unstable gait, abnormal eye movements, memory impairment, hearing voices telling her to kill her daughter, and also reported excessive sweating, millimeters of mercury, and her temperature was 39 degrees Celsius with a pulse rate of 180 beats per minute. Next slide. The prescriber gave the following medication to the patients. Tabs diazepam 5 milligrams OD for 3 days. Tabs haloperidol 5 milligrams OD. Tabs carbamazepine 200 milligrams BD for 7 days. Question 1, what is your impression of this patient? 2, what is the important key investigations for this patient? 3, what are the drug therapy problems in this patient? 4, design a pharmaceutical care plan for this patient. Next slide.
Okay, I think that's it. Thank you so much, Samuel, Dr. Samuel, for reading. Okay, so normally we are pharmacists, and when we are talking about pharmacotherapy of these CNS disorders, we must be able to get our own impression. Of course, I do have some colleagues even who are on this call, some psychiatrists like Dr. Muchibi and Dr. Ronnie, who are always giving us the diagnosis. But sometimes we have to get our own. For example, I'm going to give chance to 1 or 2 people. Tell me what they think of this patient. What impression comes to you? 35-year-old, you've seen the symptoms that are coming in, you've seen the history of alcohol use, you've seen this all sort of disorganized behavior, disorganized speech, you know. You've seen all these symptoms of memory impairments, hypertension, hyperthermia, diaphoresis. Tell me what they think about this patient. What is the impression? What comes to their mind when they get such a case? Thank you.
Anyone, you can raise the hand and I will pick you. Ticole Hope Nancy is talking about schizophrenia. Anyone else?
I see Fred has raised the hand. Can you give him a chance to just give us what he thinks? Then we shall, just in 1 minute, then we continue. Thank you.
Fahad is also saying schizophrenia. Fred, can you please type in the chat? Bwambare Jowad is also saying schizophrenia. Martin Tudiamuleva is saying alcohol withdrawal syndrome. Chigoz Yusuf is saying alcohol-induced encephalopathy. Philip is saying schizophrenia. Nsamba is saying alcohol-induced psychosis. Bwambale again is saying alcohol with alcohol withdrawal syndromes. Max today is saying alcohol withdrawal. Kathy is saying alcohol-induced psychosis. Patricia is saying schizophrenia. And Saul is saying schizophrenia. Then Ronald is saying schizophrenia coupled with alcohol withdrawal symptoms. Mutabazi is saying schizophrenia, psychosis, and withdrawal symptoms. Then an iPhone
Okay.
user is saying alcohol-induced psychosis. I think that's
Okay,
enough. We
thank you
can
so
go
much.
on.
Okay, thank you so much. So I guess by the end of this, maybe this session, we shall see. Of course, most of the people are in line, but there's a reason why they are telling you 3 days ago, 40 hours after her last drink. This is someone who has been taking alcohol for the last 15 years. Okay. And they have not given us a proper history of schizophrenia in this patient, but this follows alcohol. So we are seeing something with alcohol use disorder. Of course, we have not been told, yes, we have been told that this person has had these symptoms also for 4 years. So that means the person already was schizophrenic, but then he's taking alcohol, is withdrawing from it and all that. So we shall see about that. And as pharmacists, we need to identify drug therapy problems. And maybe Arinda, how do we summarize, how do you classify DTPs? Dr. Arinda, just quickly, if you can mention. Of course, we look at the indication, we look at the safety, we look at the effectiveness, we look at the compliance. Sometimes we also look at the cost, okay? And then for us at our level, we also look at the monitoring parameters. So you have to look at each of these drugs and evaluate them. The dose of diazepam given, is it adequate? Is it necessary? Haloperidol, what do you comment about that? What about carbamazepine? Where does it come in? Because at the end of the day, we need to be able to apply this knowledge that we get. It's not just a matter of knowing, because I'm going to give you a lot of information about all these drugs, but it's not just about knowing the drugs, but then how do you apply it? I know many people who can classify for you antipsychotics, antidepressants very well, but give them a case scenario with the symptoms, they will not even know where to start. Okay, and in my discussion, I'll be focusing a lot on the Uganda clinical guidelines because that is what we normally apply in our setting. Of course, at the higher level, like specialist level, they can even use drugs that are not in the Uganda clinical guidelines. Okay, so depression, we know that depression is low mood, sadness, fatigue, lack of interest in pleasurable activities, and all that. So when someone is depressed, of course, these are the symptoms they have. They have low energy, they have social isolation, suicidal ideation, lack of appetite, and all that, okay? And of course, it's normal to be depressed. It's not a crime, but then most of the times this depression should be self-limiting. But when it goes on, normally we shall see that when the symptoms occur normally for more than 2 weeks, then we can think of major depressive disorder. And when this major depressive disorder is being defined, there should be no history of, because when we're talking about mood disorders, we have the depressed mood and the expansive or elated mood, which we call mania. So for someone to have major depressive disorder, there should be no history of either mania, which is episode. Hypomania is a milder form of mania that does not significantly distort functioning, with the symptoms happening for about 4 days in a week. The symptoms of mania can be acute. Even in one day, someone can have symptoms of mania, but on average, it takes about 1 week. But if symptoms of any duration, as long as it requires hospitalization, that is mania. So what I'm saying is for the most abridged or best definition for major depressive disorder is when there is no episode of either mania, hypomania, or a mixed episode. Mixed episode is where someone has both of the two, either mania or depression occurring at the same time, sometimes the same day, or different days, today, tomorrow, like that, okay? So, of course, it is good for us to, when we are discussing these conditions, to first conceptualize what is depression. What does it mean when someone is depressed? Many people have been depressed before, and most of the times we think about only the psychological symptoms, but then sometimes it also comes with somatic other symptoms which are not psychological, or some symptoms are physical. For example, someone can have headache, someone can have reduced sleep, or sometimes people sleep a lot, poor appetite, low sexual drive, Sometimes people even have painful sexual intercourse. But the most important symptoms that we have to look at are low mood most of the day, nearly every day, and loss of interest in pleasurable activities. These are the most important symptoms for depression, according to the manual that guides diagnosis of mental disorders. But our UCG goes on to add lack of energy, body weakness, or easy fatigability. So these are according to UCG, at least two of the three symptoms: low mood, loss of interest, easy fatigability. Two of those should be there for 2 weeks, and then any others. Okay, the other criteria say that for depression, we need at least 5 symptoms among any of these, whereby one of them should be either low mood, loss of interest, those two only. But UCG goes on to add the third one. And then the causes can be biological, genetic, or environmental. For many of these disorders of the CNS, there are biological changes that can happen, of course, maybe in the neurotransmitters, but also genetics. There are some genes that have been identified in some of these CNS disorders. And then the environmental, stressful childhood, someone has suffered from some stress, like loss of a loved one, loss of a relationship, loss of a job, things like that, the environment. And of course, drugs. As pharmacists, we have to take a keen eye when we are taking drug history of these patients. Sometimes they are withdrawing from certain drugs. Alcohol itself can induce depression. Other drugs of abuse that we shall mention. So the neurotransmitters that play a role here are measured norepinephrine, serotonin, and dopamine. For depression, children are resort to abusing alcohol and other drugs, like I mentioned earlier, tobacco, cannabis, and others. Okay, so in children, we have to take a keen eye. And some of the antidepressants commonly used, some are not recommended in children because the studies have shown an increased risk of suicide when these antidepressants are used in children. This is what I was talking about earlier, the Diagnostic Statistical Manual for Mental Disorders Criteria 5, which talks about at least 5 symptoms in a 2-week period, where one of them should be either depressed mood most of the day or loss of interest in pleasurable activities. And it's very important that these symptoms cause a significant change in functioning, either social functioning, occupational, or important areas of functioning. For example, someone can no longer go for work because they are depressed. Someone can no longer go to school if they're a student, and other areas of functioning, self-care, all those things will be disrupted. We do, let's not only focus on the international guidelines, but the Uganda clinical guidelines. So what you've seen me listing up here, the 2 symptoms and the 3 that I've listed, the 2-week period, these are symptoms from the UCG. So you have to take note of this because we are legally bound by the Uganda clinical guidelines. Okay. So again, it is very good for us as pharmacists or healthcare professionals to have an idea of how we classify these antidepressants and probably some theories that have been put across to explain depression. We have the monoamine theory of depression that says that depression is due to reduced levels of monoamines. If you look at the Rezapine study, Rezapine is a drug that depletes monoamines, and when Rezapine is given, it actually causes sedation and symptoms of depression. So many of the antidepressants will be increasing levels of these monoamines. We can talk about the tricyclic antidepressants, selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors, monoamine oxidase inhibitors, norepinephrine dopamine reuptake inhibitors. All these basically work by trying to increase the levels of these monoamines in the CNS. Okay, so examples, I've listed them here. We have drugs like moclobemide, which are reversible inhibitors of monoamine oxidase, phenelzine, which are irreversible. And then I have drugs like the tricyclic antidepressants, which are common in our setting, are the likes of amitriptyline, imipramine, desipramine. Then the SSRIs, which we shall see later, as part of our first line treatment when pharmacotherapy is being considered. Fluoxetine is one of our first line drugs for treatment of depression. Venlafaxine is also in our Uganda clinical guidelines. You'll find it there. And then there are other drugs like bupropion, which is also in our Uganda clinical guidelines. Bupropion interferes with the uptake of dopamine and norepinephrine. Now, before initiating drugs, the first thing that is normally done is psychotherapy, which involves, of course, counseling. We also have what we call cognitive behavior therapy, which is an evidence-based therapy that deals with challenging negative thoughts. The patient is taught how to challenge all these negative thoughts, because depression is a disease of the mind. So it all starts from the mind, okay? So psychotherapy is there, including social activation. You know, there are some activities which someone will find interesting. So in management, we have to look at which activities that someone enjoys so that we can activate them. For example, someone enjoys swimming, someone enjoys hanging out with friends, someone enjoys playing football, you know, someone enjoys reading a novel, someone enjoys taking a hike with a dog, things like that. Of course, you have to customize this to the patient. We also have to look at things like interpersonal relations, you know, between the person and family or friends. And our guidelines still emphasize this. Natural therapies are also recommended. Yoga is one of those things that can actually help people to, you know, relax. Meditation. We also have some natural therapies like St. John's wort. This is hypericum perforatum. You know, sometimes they can give you a case of a patient who is on St. John's wort, and you're supposed to know that this is a very important herbal preparation that is actually approved by the British regulatory authority that is in our British National Formulary, and sometimes it has serious interactions like we shall see. And then electroconvulsive therapy, where they just induce an electric current that causes a shock that actually tries to restabilize the neurotransmitters in the CNS. Antipsychotics, such as the atypical antipsychotics, even some typical ones, risperidone or olanzapine can also be given together with the antidepressants. T3, thyroid preparations, and then lithium can also be used in augmenting where the patient is not responding. Okay, so as a pharmacist, it's very good for you to appreciate how to classify this medication and their major side effects. For example, I'm sure most of us have heard about the cheese reaction or the cheese effect, which happens when patients are on monoamine oxidase inhibitors and they experience a hypertensive crisis because of tyramine, which is found in certain foods like cheese. So when a patient is taking, let's say, phenelzine, and then they are also taking cheese or red wine, then there's a risk of hypertensive crisis, what we call the cheese reaction. And this cheese reaction is a hit and run effect because it will stay up to 2 weeks. Excuse me. Okay, I'm back. I was saying that this cheese reaction can happen even 2 weeks after the patient has stopped taking the medication because of irreversible prolonged blockade of monoamine oxidase. Then we have the TCAs, which we know also block other receptors, alpha receptors, histamine receptors, serotonin receptors. All these can contribute to their side effects. SSRIs, which are the preferred cause of lesser side effects. Then SNRIs like venlafaxine, which is associated with hypertensive crisis and suicidal ideation in certain patients. So these are things that you're supposed to take note of as prescribing the medication, because if a patient comes in with serious suicidal ideation and maybe the patient is on venlafaxine, then you have to take note of that. If a patient is elderly and you're going to give them amitriptyline, and remember that the doses we use in depression, maybe for amitriptyline, compared to what it is used for neuropathic pain, are much higher, as we are going to see, up to maybe 150 milligrams. Yet neuropathic pain, you can use 12.5. So you have to think of the sedation, the anticholinergic effects, and all that. So because at the end of the day, you have to know the monitoring parameters for all these medication, okay? So I've listed for you the medication here and how they're classified. You have to know the examples and other clinical uses. For example, amitriptyline is not only used in treatment of depression. We know it can be used in treatment of neuropathic pain. We also know that amitriptyline can be used in migraine prophylaxis. Drugs like clomipramine are also used in obsessive compulsive disorder, and so on and so forth. Okay, so the goals of therapy, you have to learn the generic goals of therapy: eliminating symptoms, reducing side effects, ensuring compliance, and then preventing further episodes. So on the right here in green, I've listed the common side effects of these antidepressants, which you have to know. Tricyclic antidepressants are known to block several other types of receptors. Alpha-1 receptors, which can cause posterior hypotension, histamine receptors, which can cause sedation, muscarinic receptors, which causes several anticholinergic effects, dry mouth, constipation, urinary retention, blurry vision, and blocking the 5-HT2 receptors, which can cause weight gain. And then some of them can cause QT prolongation, including amitriptyline itself. And remember that because these antidepressants majorly work by increasing the levels of the monoamines, then they are also likely to lower the threshold for a seizure. So drugs like amitriptyline have been documented to lower the seizure threshold and also increase the suicide risk. Drugs like citalopram are also known to cause QT prolongation. SSRIs are also known to have a lot of sexual dysfunction problems. And then I've already talked about the hit and run effects. And then bupropion, which is a drug that is also used in smoking cessation, is also known to lower the seizure threshold. So it can actually increase the risk of seizures in a patient, okay? So right about now, I'm listing the usage, what the usage recommends for treatment of depression. The first line is psychotherapy, like we've already mentioned, and managing comorbidities. Sometimes a patient is going to be depressed. They also have hypertension. They also have cancer. Of course, in the classic definition of depression, they say that the low mood should not be caused by another medical condition. But in management, we have to manage any other comorbidity. Someone has HIV, they have low mood. So if you don't manage the HIV and provide some psychosocial support, then I assure you the medication will not work. So manage the comorbidities. Psychological therapy can be enough in mild cases. And then I've already talked about CBT, behavior activation, and interpersonal therapy. So fluoxetine, please take note of the doses. You have to sit down and put these doses in your brain because there is no other way out. So fluoxetine from 20, lower dose of 10 in the elderly, maintenance of 40 milligrams. Normally, for a response to happen, we expect 4 to 6 weeks. Amitriptyline from 50 milligrams. This is really high dose, which we can shoot up to 150 after 4 to 6 weeks of evaluating. Avoid it in the elderly, adolescents, and people with heart disease. We have already mentioned what happens. In adolescents, there's a high risk of suicide. In the elderly, all these anticholinergic effects, the sedation, the constipation, the blurry vision, the urinary retention are not normally good for the elderly. Then venlafaxine, which is a serotonin or epinephrine uptake inhibitor, we start from 37.5. Remember that venlafaxine, one of the major side effects is the hypertension that comes with it, as well as the suicidal ideation. Sometimes you're going to be given a case of a patient, or you're going to have a patient who has hypertension. You're going to have a patient who has hypertension, and then probably they are prescribed for venlafaxine. Then you'll be taking the blood pressure measurements, and you realize the blood pressure measurements are always high, and yet probably it is the venlafaxine that is causing this. So that's why I said that as pharmacists, we have to take a keen eye on all the medication that the patient is given, including other drugs of abuse. Alcohol can, elevate the blood pressure. Transiently, cocaine can increase the blood pressure. All these amphetamines, these CNS stimulants. So we have to take note of all these, okay? Then sertraline, which is started at 50 milligrams. Then escitalopram, which is sertraline is good for breastfeeding. And then bupropion, which we said is also good for patients who have nicotine abuse disorder. Excuse me. So the continuation, of course, the patient is evaluated after 4 to 6 weeks. You expect the response to happen in about 2 to 6 weeks. So that's why evaluation is in 4 to 6 weeks, after which the dose is stepped up. So the therapy is supposed to be continued for 9 to 12 months. Now, as pharmacists, sometimes they're going to ask you to design a care plan for a patient, maybe was major depressive disorder, and maybe your drug of choice is fluoxetine. You're going to give 20 milligrams once a day. And then you have to state that you reevaluate the patient after 4 to 6 weeks. And if the patient is responding, you continue for 9 to 12 months. If after 9 months, the patient has a good response, sometimes, of course, discontinuation can be considered. This requires serious discussion with the psychiatrists, the patient, and their caretaker, because relapse can also happen. And there are serious withdrawal symptoms to most of these antidepressants. So nausea, dizziness, anxiety, insomnia can all happen. So we have to taper the drugs down slowly, okay? So there's also what we call postnatal depression. This is baby blues. That's what they call it. Solomon has raised the hand, but I don't know whether we are addressing the questions at once or as we move forward. Moderator, you can guide on this. I think we should
They can type the question.
Okay, you can type the
Let
questions.
us
I'll be
type the
giving.
questions. We're going to address them at once.
So I'll be giving, for example, after this, I'll give maybe 1 minute for any burning questions. We talk about it, then we continue. So there's postnatal depression, what we call the baby blues. Postnatal depression, later on I'll be talking about postnatal psychosis. These are mood disorders that are common, especially in first-time mothers or mothers who don't have a lot of support, okay? So usually within 2 weeks, 1 to 2 weeks following delivery, or most commonly within 6 weeks after delivery, some mothers suffer from postnatal depression. Sometimes the symptoms are mild with sadness, tearfulness, irritability. Remember that when a mother has given birth to the first child, sometimes they don't even know how to bathe the baby is crying, the baby is not breastfeeding, breast milk itself is not coming on its own. So the mother will get frustrated and they can end up getting depressed. So you have to take note of this, but sometimes it can be self-limiting. In 2 weeks, it can go on its own. But earlier on, I mentioned that sertraline is the preferred drug in breastfeeding because it has a better safety profile. So I want to go into schizophrenia. So moderator, is there anything that is burning? Okay, he has apologized that he raised by mistake. Can I continue?
Doctor, we have one question.
Yes.
Martin is asking that we throw more light on the difference between typical and atypical antidepressants and which one is safer to use.
Okay, so normally when these drugs are brought on market, very soon we shall be talking about antipsychotics, typical and atypical. So the typicality is based on their mechanisms of action. If I can go back to that. For example, the drugs which have a clear mechanism of action, the SSRIs, the SNRIs, the monoamine oxidase inhibitors, these are called the typical antidepressants. And also the fact that the best studied hypothesis for depression is the monoamine hypothesis of depression. Of course, the other hypothesis, like the glutamate hypothesis, in have listed a drug called the sketamine, which is a newer drug, which is an antagonist of the N-methyldiaspartate receptor that is also recently being used as an antidepressant. So the typical are the ones which have clear mechanisms of action, SSRIs, TCAs, and all that. Then they are typical in there. For example, drugs like mirtazapine, alpha-2 blockers, yeah, some of them act on serotonin receptors alone, others have mixed mechanisms of action, and so on. So that is what typical and atypical means when it comes to, and yes, moderator, anything else?
Fahad is asking the criteria for switching from one antidepressant to another.
Okay. So normally we have to evaluate. Actually, the general principle is that when you're switching from one antidepressant to another, normally you have to taper down. Of course, if the patient is not responding and they have taken a drug for a long period of time, remember that the minimum duration that someone can be on an antidepressant is normally 4 to 6 weeks. But in some few cases, because some of these antidepressants are also used in anxiety disorders, the drugs can be given for like 2 weeks and then the patient is evaluated, okay? So when switching from one antidepressant to another, we have to evaluate the patient's response. Now, there are some parameters, there are some rating scales that we can use that can give us a response, whether maybe there is 50% reduction in symptoms or not. And then if the patient is not responding, then we can switch by tapering down the first drug, and then we taper up the second drug as we monitor the therapy. So that's how we normally switch. However, you'll also realize that if you went up in practice, there's a lot of things that are happening that specialists are doing on their own based on their expert opinion. Okay, so you'll find that the way drugs are switched and all that, sometimes they don't follow the standard protocol. Thank you. So I've seen a hand from my colleague, Dr. Muchibi. Dr. Muchibi Nicholas is a psychiatrist and is my close friend. I encouraged him to join for his expert opinion. So I'll allow him to speak for probably 1 minute. Then we proceed into schizophrenia. Moderator, is that okay with you? Maybe before, also like us to take note of monitoring parameters. As pharmacists, if someone is on a tricyclic antidepressant and they ask you, what are the monitoring parameters for this patient? You have to know, first of all, the side effects of this drug. Which patient needs maybe EKG for drugs which cause QT prolongation? Which patient do you have to monitor for? You have to monitor this because some of them, like dapoxetine, like sertraline, are also used in treatment of premature ejaculation, okay? So moderator, can I allow Dr. Muchibi to for 30 seconds? You see, our time is fast spent, but we have to move forward. Dr. Muchibi, if the moderator accepts, I'll give you those 30 seconds to give your insights, and then we proceed. Thank you.
Dr. Muchibi, you can talk to us.
To him later.
Can you highlight about which drug is safe in pregnancy?
Okay, so for pregnancy, we have to be precautious. Sertraline can be one of the options, but however, in pregnancy, we have to, especially in the first trimester, we have to consider psychotherapy. And remember that in pregnancy, there are lots of hormonal changes which can actually impact in the treatment of depression. Okay, so I think we can continue. I've mentioned that sertraline would be the best option for that. In pregnancy, that one has the best evidence. Of course, some of these other drugs like escitalopram can also be used. Fluoxetine has also not shown very serious issues, but I would still go with sertraline as my best option. So, can I go on, Mr. Moderator?
We can go on.
Okay, so Dr. Mchibi is saying that postpartum blues is usually supportive, then postpartum depression is normally what requires. Okay. He's saying that the blues and the depression are somewhat different. Yes. But when you check our guidelines, some people will call it that. Maybe one leads to the other. Okay. All right. So let's go into schizophrenia. Schizophrenia, we all know when someone has all those disorganized behavior, disorganized speech, delusions, hallucinations, and most importantly, the cognitive deficit. The cognition deals with thought processes, understanding, performing tasks, you know, how someone gets information and interprets it to make a decision about it. Actually, these psychiatrists can do a cognitive examination whereby they can ask a few things, a few questions to see whether someone actually has a good comprehension of what is happening around them. If I ask you, for example, if you're 5 people and then I give you 10 mangoes, how many mangoes will each person get? That is a quick test that I'm trying to see whether there's someone understands what I'm saying. Or if I told you you have 4 students and you have to share with them 10 loaves of bread, how many will each get? So these are things that they can do quickly to assess cognition. If someone is born in 1920, how old are they today? You know, some sort of simple questions, okay? So I want us to take note of the positive and negative symptoms of schizophrenia. The positive symptoms are those that are easy to recognize. The delusions, the hallucinations, the disorganized behavior, the disorganized speech. Now, at this level, I would like us to know if I say delusions, okay? Delusions are fixed false beliefs which are not accompanied with any evidence to support them. There are different types of delusions. I don't want to go so much into that, but we have what we call the grandiose delusions, which are most common. Delusions of self-worth, delusions of self-importance, delusions of someone feeling as if they are very powerful. If you remember Napoleon, sometimes they are called Napoleonic delusions. So it's like someone saying, I'm the president, I own this country, I'm a surgeon, you know, I'm the richest person around, things like that. Those are delusions, okay? And then we have hallucinations, which are, of course, perceptions in absence of stimulus. They can be visual or auditory. Auditory are very common, whereby people are hearing voices telling them to do things, commit suicide, you're worthless, you know, things like that. Why don't you kill your child? Okay. And then the speech sometimes is not coherent, or you cannot get meaning out of someone's speech. And the behavior can be sometimes violent, sometimes it's catatonic. Sometimes we see these patients imitating other people, the way they speak, the way they talk. Sometimes a patient can act as if they are in a coma or in a stupor, and so many things. I've also seen patients like when I went to Butabika, who would stand and flex their limbs and put them straight, and then they'll stand in the rain. All that is not normal. And then the illusions, which are misperceptions of a stimulus. A stimulus can be there, but it's being misperceived. And then the negative symptoms are those that are not easily recognizable or something that is abnormally present. Most of them start with A, anhedonia, which is lack of interest in pleasurable activities, avolition, which is lack of motivation, blunt affect. Affect deals with mood. So sometimes people don't have, their mood is flat, or there is apathy, which is lack of emotions, poverty of speech, social isolation, suicide ideation. All these are negative symptoms. And then, of course, the cognitive dysfunction, whereby someone's functioning. I've talked about cognition before, which deals with intelligence, which deals with thought processes, which deals with interpretation of information to perform tasks, which deals with working memory and attention. Sometimes, for example, in a webinar, someone cannot concentrate even for 15 minutes. They're easily distracted, and their memory cannot sieve what to store and what not to store. And I remember in one of my, when I was doing my PSU exams, we were asked to state the positive and negative symptoms of schizophrenia. So what are the key laboratory findings? I'm going to talk about this. And of course, when someone has a mental issue like schizophrenia, which has disorganized their thoughts, they are hallucinating and all that, as pharmacists, we have to think about, apart from the obvious, looking at the family history, looking at the environmental factors, we have to think of also other causes of mental impairment or other causes of this kind of psychosis. For example, drugs. Cannabis is a known psychomimetic, a drug that can cause hallucinations. Drugs like ketamine can cause hallucinations, okay? We've already seen in our case that I shared, a patient who was withdrawing from alcohol, who had serious delirium tremens, which also presents with serious agitation and hallucination. So we have to think of the drug history, substance abuse, and sometimes that's why a urine drug screen is recommended. Infections are common triggers. I have a patient who is elderly, but each time when they get a UTI, they get this sort of disorganized behavior, agitation, and all that. And as we are going to see, this psychosis can be acute or it can be chronic. The ECG classifies it as acute or chronic, depending on the duration of symptoms. If the symptoms are there for more than 3 months, it's considered chronic. Otherwise, less than that is considered as acute. And then when we talk about psychosis, we also ought to know that psychosis is a broader term, okay? So alcohol can induce psychosis, HIV can induce psychosis, drugs can induce psychosis. But when we are discussing about schizophrenia is a classic psychotic illness that is categorized by the DCM-5 criteria, according to 2 criteria that I'm going to mention, criterion A and criterion B, whereby we look at some of these positive or negative symptoms being present, as well as the cognitive dysfunction, okay? So I didn't want to be extremely theoretical. However, at our level, it's very important that one of the most studied hypotheses for schizophrenia, because there are about 3 neurotransmitters that are majorly involved in schizophrenia. One, which is the most important, is dopamine. So excessive dopamine has been implicated in schizophrenia. And then we have also glutamate, a dysfunction of glutamate, and then serotonin. So we shall see that drugs, for example, that block glutamate receptors, for example, ketamine, can actually cause hallucinations. And then drugs that also can increase serotonin can also induce hallucinations. And that's why some of these antipsychotics can actually block serotonin receptors. So I want us to know the 4 major dopamine pathways in the CNS and their functions: mesolimbic, mesocortical, nigrostriatal, and tuberoinfundibular. So the mesolimbic is majorly for pleasure, but when we have too much dopamine in this pathway, there will be symptoms of schizophrenia that we have seen. To the nuclear accumbase. Then we have the mesocortical, which is majorly important in cognition and mood. And actually, studies have shown that reduced dopamine in this mesocortical pathway normally contributes even though they're used in treatment of schizophrenia, when they block dopamine in this mesocortical pathway, they can induce the negative symptoms of schizophrenia, what we call the neuroleptic induced deficit syndrome. We also have to take note of the nigrostriatal pathway, which is a pathway that is important for voluntary movements, okay? So when it comes to Parkinson's disease, we see that patients who have Parkinson's disease suffer from dopamine hypofunction in this pathway. However, the drugs that block dopamine receptors in this pathway, for example, the antipsychotics, because they are not selective, they induce extrapyramidal side effects. Why are they called extrapyramidal? Because when you look at this pathway, it is somewhat located outside the pyramids of the brain. And basically, we see side effects of involuntary movements, the dystonias, the akathisias, and the classic drug-induced Parkinsonism. You know, for Parkinsonism, there are three cardinal signs. We have the muscle tremors, the muscle rigidity, and bradykinesia. And then finally, the tuberoinfundibular pathway, which is important in inhibiting prolactin secretion. Why is it important for us to know these pathways? First of all, we are going to see that some of these antipsychotics, especially the first generation, what we normally call the typical, can block dopamine receptors in the nigrostriatal pathway, causing serious extrapyramidal side effects. And that is why when patients are put on typical or first generation antipsychotics, they're normally given drugs like benzexo or trihexyphenidyl and other anticholinergics. Okay, so please take note of that. And then, so I've talked about this. I will not go back in the symptoms. The criterion for sorry. So the criterion A and B for the diagnosis statistical manual of mental disorders, criterion A for at least 1 month, there should be these symptoms, and then the impaired functioning, which I've already talked about. And then we classify them as typical or atypical, but for better, we can say first generation and second generation. The typicality is based on the mechanism of action. Typically, schizophrenia is due to elevated dopamine in the mesocortical pathway, which causes the positive symptoms. And typically, the typical antipsychotics of first generation work by blocking these dopamine receptors. So these drugs can be classified into low potency and high potency. So the low potency means, of course, a higher dose is required. The high potency means that a lower dose is required. So drugs like haloperidol, trifluoperazine are low potency. Drugs like chlorpromazine, pyridazine drugs like haloperidol and trifluoperazine are high potency. Chlorpromazine, haloperidol are low potency. I also have to mention that the low potency drugs tend to block histamine receptors, alpha receptors, serotonin receptors, and muscarinic receptors, and that is why they cause more side effects in terms of anti-muscarinic side effects, dry mouth, and all that, postural hypotension, just like we saw with the antidepressants. Secondly, the first generation antipsychotics cause more extrapyramidal side effects compared to the second generation or the atypical. So the atypical, they are called so because they don't only work by blocking dopamine, but others can block serotonin receptors, and others can act as partial agonists even on these serotonin receptors. So we have drugs like clozapine, risperidone, aripiprazole, quetiapine, and others. Some of these drugs are in our UCG. Risperidone is there, clozapine is there, quetiapine is there, as we are going to see. This is what I was talking about: low potency, high potency, first generation, second generation. These drugs can also be given as injectables, what we call the depot long-acting. For example, in our UCG, we have haloperidol, we have zoclopentixol as part of the longer-acting injectables we give in patients, okay? So what you have to know about these antidepressants is that, rather antipsychotics, one is they are typically blockers of dopamine D2 receptor, and two, they are divided into first generation and second generation, that is typical and atypical, and three, the typical are divided into low potency and high potency. And then the low potency tend to have to block a lot of other receptors, as I've already mentioned, like chlorpromazine can block histamine, serotonin, muscarinic, and alpha receptors. Okay, and of course, as you may know, the first generation tend to cause more extrapyramidal side effects compared to the second generation. So all these you can read through later. Maybe I also have to mention that when it comes to the side effects, in here I've put in a slide on the therapeutic uses of these antipsychotics in terms of treatment of schizophrenia and in terms of propensity to cause extrapyramidal side effects and in terms of long-acting injectables. You can go through this later. And the fact that clozapine, which is normally reserved for treatment-resistant schizophrenia, that is when a patient has been tried on 2 or more antipsychotics and they are not responding, we can go for clozapine. So clozapine is considered last resort because of the fact that, first of all, it requires serious monitoring. It causes agranulocytosis, so it requires monitoring, normally weekly, for about 6 months. So that makes the cost, the treatment cost expensive, but also it is reserved for those serious cases. If someone is severely suicidal, actually studies have shown that clozapine can even be initiated as a second-line therapy, okay? Otherwise, it's normally given more of a third line. If a patient has experienced serious extrapyramidal side effects also, clozapine is one of those drugs that tends to cause less extrapyramidal side effects, okay? So in terms of side effect profile, the first side effect you have to take note is the extrapyramidal side effect. I've already mentioned that they are called extrapyramidal because of the fact that these side effects happen as a result of blocking dopamine in the nigrostriatal pathway. Please take note of that. And they're basically divided into two. Okay, maybe I'll say into 3. But first you have to know the ones that happen acutely. The dystonias. Dystonias are just, movements, maybe abnormal movements of the neck, akathisias, where someone is probably restless, and the drug-induced Parkinsonism, which is the tremors, bradykinesia, and rigidity. But you also have to take note of the tardive dyskinesia. Okay, so tardive dyskinesia is a side effect that comes in when a patient has been on these drugs for many months and or years, and it involves disturbances in movements of the muscles of the jaws, the lips. Sometimes the patient is going to stick out their tongue, or sometimes it comes in sort of choreoform movements where the patient is as if they are actually dancing. So I want you to take note of the extrapyramidal side effects, and then I want you to take note of the agranulocytosis, which is common with clozapine, and also the metabolic side effects. The metabolic side effects are issues to do with disturbances in, for example, lipid profile of the patients, diabetes, that is this, some of them will cause hyperglycemia, weight gain, and also hormonal disturbances, gynecomastia, loss of libido, hyperprolactinemia, loss of periods or amenorrhea. These are more common with the second generation antipsychotics. The first generation antipsychotics normally cause a lot of extrapyramidal. The second generation normally cause a lot of the hormonal side effects. Please take note of that. And then some of these drugs are known to cause cardiac side effects, like haloperidol, which causes QT prolongation, quetiapine, thioridazine, ziprasidone. So also take note of that. And then the sedation, which is very common with the first generation low potency, as well as clozapine and olanzapine, okay? So why are we talking about side effects? Because for monitoring parameters, you ought to know about this. So I've also listed for you here their propensity. Of course, when you look at this list of drugs, if I removed all these pluses that I've put, the first thing you have to do is to classify the drug. Is it first generation or second generation? Then you will know that first generation have more extrapyramidal side effects. And if it's low potency, it will have more anticholinergic side effects. If it is second generation, it will have more effects on weight gain and also on prolactin, okay? So the ECG gives us drugs like chlorpromazine, haloperidol, olanzapine, risperidone, quetiapine, as well as clozapine, okay? This I've listed here. And then It also goes into talk about, of course, in schizophrenia, the patient has to also be evaluated for 4 to 6 weeks, and then therapy continued for 12 months. Non-pharmacological management is very important. The management for extrapyramidal side effects, which is benzexol, we've talked about it. The UCG recommends 2 milligrams BD initially, and then 2 milligrams PRN, and then the long-acting injectables. These are very important in ensuring compliance. Flufenazine, haloperidol, zuclopentixol, flupentixol. These are also important. They are given every 2 to 5 weeks, every 4 weeks, or monthly, okay? So, and then for tardive dyskinesia, normally, as I mentioned, drugs like clozapine tend to have less tardive dyskinesia, but when it happens, it is very hard to reverse. However, FDA has approved valbenazine and deutetrabenazine for tardive dyskinesia. Otherwise, drugs like clozapine, drugs like vitamin E, drugs like clonazepam, drugs like ginkgo biloba, which I know most of you know, have also been implicated. Postnatal psychosis, just like we saw for postnatal depression, again, this happens in mothers where they become delusional. Sometimes they'll say the baby is defective or dying, the baby is Satan, the baby is an evil spirit and all that. And the mother will be hallucinating, and she will threaten to kill the baby or even kill herself. The high prevalence of suicide and infanticide. So this is normally treated as an emergency according to our Uganda clinical guidelines, and haloperidol 10 milligrams of chlorpromazine can be given 8-hourly BD. And if the patient is restless or agitated, we can use diazepam, which we know is an anxiolytic. So other things I've not talked about here. One, other clinical uses of these antipsychotics, you're going to see them in bipolar disorders. You're going to see chlorpromazine treatment of hiccups. You're going to see chlorpromazine in treatment of Tourette syndrome and many other indications. Then two, there's something called rapid tranquilization, which you must know, whereby the antipsychotic or the benzodiazepine is given to sedate a patient so that the patient can remain calm, to reduce harm to the patient and the people around them, as well as allow diagnosis by medical personnel to take place. The patient should be able to communicate with the medical personnel. So that is called rapid tranquilization. And normally they use either of these antipsychotics, either haloperidol, olanzapine, risperidone, or even the benzodiazepines like lorazepam. And the most recommended route is the oral route, but even the IM can be used. I've talked about neuroleptic induced deficit syndrome. And then also I want you to know about neuroleptic malignant syndrome, whereby when someone has used these an overdose of the antipsychotics can cause excessive contractions of the muscles. Actually, for you to understand neuroleptic malignant syndrome, you have to know that the muscles are contracting. When they are contracting, they are producing myoglobin, so there is myoglobinemia. When they are contracting, there is sweat that is being produced, so the person is having diaphoresis. Sometimes the person is going to have convulsions, hypertension or high blood pressure, hyperthermia. So that's why in the treatment, we can use muscle relaxants like dantrolene. We can use drugs like diazepam, which is also a muscle relaxant and an anticonvulsant. And then we can give hydration to the patient, as well as bromocriptine, which is a dopamine agonist. Then the depot preparations, which I've talked about, tardive dyskinesia, pimavanserin, which is a 5-HT2 antagonist that is commonly used in treatment of patients who have Parkinson's disease. When they develop psychosis, they are either given clozapine, low dose, or pimavanserin, and then there's ketamine, which is a newer antidepressant, and then the drug interactions of these antidepressants. So, moderator, can I go on? As I told you, these things are very many.
We have a few questions. Doctor, can you attend to questions? One or two?
Yes, please. Let's attend to those.
One is saying, since schizophrenia is considered as a chronic mental illness, for how long is it considered? For how long is considered free symptoms? I beg your pardon, for how long is the patient considered symptom-free on treatment before tapering the dose is considered?
Okay, so in discontinuing, just like we saw for antidepressants, we have to look at a chronic period of about 6 to 9 months. If the patient is symptom-free, then we can discuss and consider discontinuation. Remember that in treatment of schizophrenia, the minimum duration of time that is recommended is a minimum of 12 months, even in an acute episode. That is according to studies. So it means that after that time, we have to look at the patient for over 9 months. Of course, the challenge is we don't review our patients, but you can observe them every 3 months and then recognize other triggers. I've talked about infections, I've talked about alcohol and drugs, before you can consider either tapering down and discontinuing the drug. So you have to look at a clinical picture of the patient and the duration of about 6-9 months when the patient is symptom-free. Yes, any other concern before we go on?
Ronald is asking some of the new medication available on Ugandan market for both antipsychotics and antidepressants.
Yes, so for that one, we probably have to check the NDA registrar to confirm which drugs are on the market. But for me, I'll talk about what is published. I've talked about ketamine, a very new drug. But some of these drugs are available. Sertraline is available. Escitalopram, I think, is available. Many of them are actually available. And then for the antipsychotics, risperidone is available. It's not a new drug, but it's a very good drug and very potent. You've seen doses ranging from 2 milligrams to 8 milligrams. I'm not sure if aripiprazole, ziprasidone are available. You just have to check the register. Good thing we are pharmacists and then we know what is available. But I know the specialists can prescribe any of these drugs depending on response. And also we have what we call special importation that can be considered if a patient really needs the drug. Yes. So
Aripiprazole is
the setting of
available
clinic, when a patient really needs the drug.
I was saying
Yes,
that aripiprazole is
moderator, please go on.
available, and there is also risperidone in formulated for IV and depot.
All right. Any other burning question? We have to continue because we have a lot of things. Anything else?
Let's continue.
That we have to. Okay.
We can.
Okay, fine. So next is alcohol use and substance use disorder. Now here I focused on alcohol because it's most commonly used, and I want to mention that when we talk about a use disorder, one, we look at intoxication, okay? For example, if someone is abusing alcohol, one of the problems that can happen is that they'll take a lot of alcohol in one go. Of course, there are recommended levels of alcohol that can be not toxic, but if someone goes above the recommended blood levels, then that is intoxication. It can happen even in a new drinker. For example, someone has not drunk before, but then on the first attempt, they take too much of alcohol. We call that acute alcohol intoxication, and it comes with distortions of behavior, distortions of cognition, distortions of judgment. That's why you'll see that some people, when they take alcohol for the first time, they are going to talk a lot of things that are not necessary, make a lot of confessions, things they'll regret later. That is acute alcohol intoxication. And the same thing happens with other substance use disorders. Then there's harmful use. So harmful use means that a person is going to continue using a drug or alcohol, even if they know their harmful effects. For example, we know that alcohol is known to cause damage to the liver. It is one of the leading causes of liver fibrosis and liver cancer on its own. It can cause gastritis, pancreatitis. It can cause delirium tremens. It can affect you look at your body entirely, the CNS, it can cause psychosis, delirium, depression. On the GIT, it can cause gastritis. it can cause pancreatitis, it can cause cancer even of the GIT, cancer of the liver, it can cause malnutrition. It has a lot of harmful effects. It impairs judgment. So someone will continue to use this alcohol, even if it's even destroying their family, their relationships, their working environment. Someone can lose their job and all that. So that is called harmful use. So you'll find that someone will continue to use a substance, including alcohol, despite of the harmful uses harmful effects that they already know. And dependence, as we already know, means that when someone stops using a drug, they go into withdrawal symptoms. However, also when we are talking about dependence syndrome, it is whereby someone will not be able to function without taking a given drug or alcohol. So you'll even find that maybe someone is a surgeon and they will tell you that, I've seen some surgeons, by the way, they use drugs. There's one I know who was using pethidine, and he cannot go to the theater without injecting himself with pethidine, or some of them without taking some alcohol. So that is called dependency syndrome, whereby someone feels they cannot function without a given substance, in this case, alcohol. And of course, in dependence syndrome, that leads us into withdrawal, whereby when someone now stops taking a drug, they go into withdrawal symptoms. And of course, what causes these withdrawal symptoms majorly is the fact that the body is stressed. There will be release of noradrenaline, so there will be palpitations, anxiety, tachycardia, sweating, these symptoms of noradrenaline, agitation, restlessness. These are some of the symptoms of withdrawal, in addition to the mental symptoms like hallucinations, delusions, and then other symptoms like insomnia, all those symptoms. You've seen people having tremors, they are shaking, all those are symptoms of withdrawal that happens when someone has been using a drug for a long period of time. Sometimes it can take even just 1 month of continuous use, or 3 months, and then someone can go into withdrawal, or some drugs can take years. Okay, so for us to talk about in the slides I talk about acute intoxication, I talk about harmful use, whereby in harmful use I've mentioned what it causes, and the criteria is someone should be taking 5 drinks in a given occasion, or more than 2 drinks a day, or drinking every day. So you find that people consume alcohol almost on a daily. And then alcohol can also cause harm to the fetus. We have what's called the fetal alcohol spectrum disorder. Majorly, it looks at the mental status and growth retardation of the patient, and then congenital abnormalities of the child. So for dependence, there's a criteria here. Large amounts taken every day. Someone takes the alcohol every day, and as we shall see later, there's tolerance, there's dependence, there's continued use, there's a criteria that I'm going to talk about, and then the complications which I've mentioned that come with alcohol. But you have to take note of thiamine deficiency, and that is why people who take alcohol for long suffer from the one-neck encephalopathy. We sometimes call it one-neck-Korsakoff encephalopathy. The Korsakoff's part represents the confusion and the memory loss that comes with taking alcohol, and then the one-neck part represents the agitation, the hallucinations, the unstable gait, okay, and the abdominal eye movement. So in talk about the one-neck encephalopathy, there are 3 symptoms you must think about: the agitation, the unstable gait, and then the eye movements. So this is the criteria. Please, you can read through this later because of time. And then in the withdrawal state, I've mentioned that for the criteria for alcohol use, you have to take note of that urge to take alcohol, difficulty controlling how much someone takes, the withdrawal, the tolerance, neglect of other activities or other behaviors, and then persistence of use despite the harmful effects, okay? So I've talked about the symptoms of withdrawal. It can be mild, severe, or very severe. We shall see that in very severe states, this is what we call the delirium tremens, which can actually even cause death. And then it can last from 6 hours to 6 days. after someone has taken their last drink. So sometimes the person is going to come and they last took their last drink maybe 3 days ago, just like the case I gave you, but then they're actually withdrawing from alcohol too. These are some of the symptoms. You can look at them later. The management for alcohol intoxication, as you may predict, you have to think about replacing the lost fluids. Remember, alcohol inhibits ADH, so you have to replace the fluids with normal saline. And then alcohol is also known to cause difficulty in breathing, so ventilation may be required. It is known to cause hypoglycemia, so normally dextrose 50%, 20 to 50 mils is given intravenously. If that's not possible, it can be given via nasogastric tube or rectal, and then continue with D5 or 10% until the patient wakes up. And then the patient is also given thiamine 100 milligrams in 1 liter of D5%. So ventilation, managing hypovolemia and hypothermia, managing the hypoglycemia, and then giving thiamine to prevent the one-neck encephalopathy. And then for chronic use, I've already talked about the symptoms, and I've already said that for one-neck encephalopathy, it's normally due to thiamine deficiency, and there are 3 cardinal signs: the mental confusion, the unstable gait, and then the abnormal eye movement. So for withdrawal states, again, I've already talked about the symptoms: mild, moderate, severe. The management is just like what we saw earlier on, involving giving IV fluids, giving dextrose 50%, and then D5 until the patient can eat or can speak, and then giving thiamine, okay? In very severe cases, what we call delirium tremens. Delirium tremens is characterized by serious agitation and confusion and hallucinations and autonomic hyperexcitability. So the patient will have tachycardia, hypertension, hypothermia, and sweating, okay? And it is actually fatal. It can happen even 3 days after the patient has stopped taking alcohol, okay? The symptoms can persist for some days and it is fatal. Some patients can die. And that is why when we are treating patients who have alcohol withdrawal, we give benzodiazepines. I'll talk about them, which can help the patient not go into the withdrawal symptoms. So management, we use the same criteria I showed earlier: D50, 20 to 50 mils, D5, and then diazepam, which we know is a benzodiazepine that helps to calm down the patient. By the way, when diazepam is not given in these high doses, that is 5 to 10 milligrams every 10 minutes, then the patient can even die. By the way, studies have shown. So diazepam has to be given. So in the case I gave you, for example, this patient, you see that the diazepam dose that was being given was not specific enough. And if diazepam is not working, we can go for phenobab, though we have to monitor hypotension and respiratory depression. If delirium persists, then we can go for haloperidol. And then for the encephalopathy, it's normally recommended to give thiamine 100 milligrams IV or IM 3 times daily for 3 to 5 days, okay? So you have to take note of what you call benzodiazepine refractory delirium, whereby if a patient has received more than 200 milligrams of benzodiazepines, most commonly diazepam, which is long-acting, or chlordiazepoxide, and they are not responding in the initial 3 hours, or more than 400 milligrams in the first 8 hours, this is called refractory because it's not responding to the benzodiazepine. So in that case, phenobab or propofol may be considered, but we know there's a risk of hypotension and respiratory depression with this particular drug. So the other drugs are disulfiram, which is normally used in detoxification, but it's rarely used. It has to be highly supervised. Disulfiram is given to patients who have already accepted to stop drinking. So each time they drink, they get very bad side effects because disulfiram is increasing the formation of acetaldehyde by inhibiting aldehyde dehydrogenase, which causes nausea, vomiting, sweating, and so on. Then acamprosate, which is normally given to reduce relapse, okay? So normally what alcohol does is that alcohol is a drug that actually is a GABA potentiator. So normally when someone stops taking alcohol, the glutamate levels go up very fast. And these glutamate levels, there's an imbalance between GABA and glutamate. So that's why acamprosate, which is an N-methyl D-aspartate antagonist, can restore that balance, and it reduces that emotional and physical distress, which can make someone relapse. Okay. Naltrexone is an opioid antagonist that is known to reduce cravings that happen when someone is on alcohol. So if someone is addicted to alcohol, they will have that urge, which we have seen that happens in alcohol use disorder. So naltrexone can be given to stop that. Okay. So thiamine is given for at least 2 weeks daily in people who have alcohol dependence to prevent the encephalopathy slowly. I've not gone into them because of time. Already, so we've been here for to prevent this with smoking itself, and then drugs like bupropion, which is an antidepressant that we talked about earlier, and then drugs like varenicline. Then for opioids, we are losing a lot of people these days due to opioids, pethidine, which can cause respiratory depression. Again, the protocol involves using drugs like methadone, which is a long-acting opioid that occupies the receptors for long, buprenorphine, which is a partial agonist, and then, of course, clonidine, which is a drug that actually inhibits release of norepinephrine as an alpha-2 agonist. And then in acute situation or overdose, we can use drugs like naloxone followed by naltrexone. Then benzodiazepines, amphetamines, cocaine, and cannabis. I didn't go much into this because of time. So, moderator, again, are there any quick comments that we can address before I go into the last session?
Yes, there are some few questions. One, why are you adding glucose? The management of alcohol dependence.
Okay, so
Can you hear me?
you know that when someone is dependent on alcohol, most times the symptoms, actually one of the baseline tests that we do is blood glucose. You know, even the case I gave you earlier, we have to do blood glucose because alcohol is known to cause hypoglycemia. And also we know that, yes, so we have to give this glucose because we know that the hypoglycemia is a common occurrence in people who have alcohol dependence. Probably it interferes with uptake of glucose, but also it can cause loss of appetite, okay? That is why when we are suspecting alcohol withdrawal, alcohol use disorder, like in the case I gave you, the patient had loss of appetite. So loss of appetite can also be one of the presentations. So automatically we think this patient will have hypoglycemia, okay? So we have to give them glucose. Of course, it's good to do the baseline to know the blood glucose levels before giving, but most of the time is that we have to give them. So that is why it's important to add glucose. Then for thiamine is known to prevent this one encephalopathy. You know that vitamin B12 is very important in some of the symptoms we mentioned, and alcohol is known to cause depletion of vitamin B12, which normally affects the neurons in the brain and causes that classic presentation of the three symptoms I talked about: the disorientation, the unstable gait, and the abnormal eye movements, which happens in the one-week encephalopathy. And then I said that for the Korsakoff's part, you know, there are two things: one-week Korsakoff encephalopathy. So the one-week part is those three symptoms I've mentioned. Then the Korsakoff's part is the memory impairment. Okay, and that's why we have to give thiamine to replace it there. I don't know if that is okay. And then moderator.
Yes, Doc. Another question, is there a difference between addiction and harmful alcohol use?
Yes, there's a difference. When we say harmful alcohol use means that the person is using alcohol in a way causes physical and mental harm. They continue to see that this alcohol is causing harm and they do not stop. For example, someone is using alcohol, they are losing their job, they are depressed, they are psychotic, they tell them you have liver, because we know that in some of the investigations we see MCV and GGT, and then when the GGT is elevated, that means that the liver is being inflamed. There's hepatitis, someone has hepatitis, they continue to use. Someone knows that this alcohol is going to harm the baby, they continue to use. Someone is seriously malnourished, they are not having appetite, they're having insomnia, they continue to use. So that is what we call harmful alcohol use. Now, addiction and dependence sometimes are more or less the same. So we find that addiction means that when someone stops using a drug, they experience very dangerous, deleterious, or harmful effects, and they will continue to use this drug. However, the similarity is that in both addiction and harmful use is that the patient most of the time is aware of the harmful effects of the drug, but they will continue to use. So addiction means that someone continues to use a drug despite of its harmful effects, and they'll do anything within their power to get the drug. And the moment they stop taking this drug, they have the acute withdrawal. Remember that we have what we call positive reinforcement and negative reinforcement, whereby negative reinforcement is whereby someone will use a drug because the moment they stop using it, they experience harmful withdrawal effects. And then positive reinforcement is whereby someone is using a drug because of the happiness, the euphoria, the pleasure, the calmness they derive from it. So I hope that is okay.
Doctor, you said we give 100 milligrams of thiamine in D5. This one is asking, is there an effect of using thiamine alone without putting it in D5?
There's really no effect of using it alone because it can still be given alone, but we are trying to tackle the two problems at the same time. And we are also trying to see what will really help our patient respond better. So it is the thiamine in D5 that would be the best practice. However, thiamine is given alone, it can still be given alone. And we also know that actually alcohol can reduce, because we say that it depletes thiamine. How does it deplete it? By reducing the absorption of this thiamine in the intestine, okay? And we also know that thiamine is very important in the metabolism of glucose. So probably that's why these two actually are better given together, because thiamine also plays a role in metabolism of glucose and therefore glucose production. So giving it alone may actually not help the patient in this case. So we have to give them together to have that kind of synergistic effect, if I should say. And I think that also answers the question. I think someone was still asking about thiamine and glucose.
So Martin Tuyamlev is asking, how long should naltrexone be given?
Naltrexone, okay, now normally these drugs are normally given they should be supervised, because this is a drug that is given to reduce cravings, because the moment someone takes this naltrexone, it reduces the stimulation of the opioid receptors in the CNS, reducing the cravings. So how long should it be given? As long as someone is still under treatment. Dr. Muchibi is here, but I know that this detoxification process, because detoxification involves the process of getting the patient off the dangerous withdrawal effects and then getting the patient off the abuse of a given substance. So as long as the patient is still on that, then we have to continue giving. But I'll ask my colleague, Dr. Nicholas, to comment on that or to type in the chat, because he's a practicing psychiatrist and a very competent one at that. I think he will contribute to that. Yes, moderator.
Someone else is asking why we are using naltrexone, not naloxone, yet they are all
Naloxone
opioid
is short
receptor
acting.
antagonists.
Naloxone is normally short acting. It acts within a few seconds. And here we are looking at a more prolonged effect. So naltrexone is a little longer acting. So that's why we use naltrexone, not naloxone, which is normally given as an antidote in overdose of opioids. Moderator, please, can we answer like one more question and then we proceed because of time?
Someone else is asking whether we can use metronidazole instead of dicyphram because metronidazole is readily available.
So we cannot use metronidazole. However, there are drugs that cause the disulfiram-like effect with alcohol, and one of them is metronidazole. That means that when metronidazole is taken together with alcohol, it will inhibit that aldehyde dehydrogenase that we talked about and form acetaldehyde, which will give very bad side effects. So the only thing we can do is counsel patients so that they do not take alcohol with metronidazole. There are several other drugs, like some cephalosporins and some other drugs that can cause this effect, but that is not an indication for metronidazole. Thank you.
A last one. Some people claim to have used urine for alcohol intoxication and it have worked. Is there any scientific-based reasoning behind it?
So recently I had that discussion with one, I think it was a physician, and what we know is that urine, actually they used to say, if you look at our history, they used to say urine of a pregnant woman or someone who is diabetic, because of the hypoglycemia that actually the alcohol would cause, this urine would, actually they would say urine of an elderly woman. So by then most elderly women would have DM, and then it would help to probably reduce that hypoglycemia. So I guess that is what it was, but there's no evidence and we cannot, as scientists, we cannot support that. Thank you so much. Can I proceed, please? Because time is fast spent and you still want me to talk about epilepsy. Thank you so much. Members, you can keep typing your questions in the chat and then we shall probably comment on that. So the last session is about epilepsy, which is a condition that is characterized by unprovoked seizures. When we are defining epilepsy, the key thing is recurrent unprovoked seizures. Seizures can occur with or without convulsions, okay? So when we say that someone has a seizure, in simple terms, it means that there's excessive firing from a group of neurons in the brain. And this firing does not have a particular order or a particular pattern. That is what the word seizure means. And now when we talk about a convulsion means that the muscles are moving, the muscles are contracting, the muscles are relaxing. That is what the convulsion means. So when we talk about epilepsy, it's a chronic condition whereby someone has recurrent unprovoked seizures, okay? So the seizures can be with convulsions or without convulsions. That's why we have what we call convulsive epilepsy and non-convulsive epilepsy. For example, we know that in patients who have what we call petit mal or absence seizures, normally these are seizures whereby you don't see the patient convulsing, but you see changes in awareness, behavior, emotions, and all that, okay? So the diagnostic criteria, our guidelines say that at least someone should have had 2 seizures in the last calendar year on 2 different days, okay? And we know that seizures can be caused by other things. For example, if someone has a brain injury, if you went to the ward of brain injuries, you'll find a lot of seizures there. If you went to the emergency ward, people brought in after maybe trauma, you'll find a lot of seizures there. People who have CNS disorders like meningitis, cryptococcal meningitis, bacterial meningitis, they can have seizures. Febrile illnesses, malaria, cerebral malaria can cause seizures. Drug overdose like CNS stimulants or withdrawing from certain drugs can cause seizures. So Those isolated events or acute events are not classified as epileptic. Okay, so let's take note of that. And then, basically, the causes can be metabolic, genetic, congenital. Studies have shown that if a baby is traumatized during childbirth, they're likely to suffer from a seizure later in life or seizures. And we have said if someone has had at least 2 almost seizures in the last calendar year on different occasions, then they're epileptic. So it's about firing. And we know that in the brain, we have those neurotransmitters that cause firing, and then those ones that reduce the firing. So glutamate causes stimulation, GABA causes inhibition, okay? So anything that causes too much glutamate or too much stimulation or excitation in the cells, either increased GABA or inhibition or what we call the inhibitory synaptic potentials can control the seizure. Remember, we have to distinguish between a seizure and epilepsy. Not all seizures are epileptic, okay? Then we have what called status epilepticus, which is an emergency, which happens in epileptic patients whereby they have convulsed and the convulsions are lasting more than 30 minutes, or a patient has had uninterrupted seizures occurring at this, continuously, okay? Initially, the baseline used to be 5 minutes of uninterrupted seizures, or a patient is given 2 doses of diazepam and they are not responding. Seizures can be partial, generalized. I'll not go into that because of time, but I've classified them here depending on which part of the brain is involved. Partial or focal, if one part of the brain is involved, then generalized if the entire brain is involved. Okay, and then the diagnosis is normally based on the electroencephalogram, MRI, of course. Now, the challenge is that the electroencephalogram should be done when the seizure has just taken place. If the electroencephalogram is done many days after the seizure, sometimes it will be normal. So here I show you the normal electroencephalogram, which is something that measures the conduction, how the brain is conducting, okay? For the treatment, so here I outline some of the principles. Normally it's good to start with a single drug, low dose, keep, tapering it up. And if someone is seizure-free for 2 years, we can consider stopping. One isolated seizure may not require further treatment. So we start with one drug, elevate it up monthly, every 3 months, and then the patient should not interrupt treatment. We lost a friend during our master's class. He was a non-epileptic patient, and he just went off medication, and then he just passed on. So it's not good to interrupt treatment because this can trigger seizures, and it's good to even it's good to recognize the triggers of seizures, because epilepsy can lead to if a drug is in than 50% reduction, then we can say the treatment is ineffective, and then we can taper down the drugs. We have to look for tolerance, because some of the drugs, for example, carbamazepine, can undergo what we call autoinduction. So it induces its own metabolism, which is more noticeable after 4 months of therapy. You'll find that this patient now needs a higher dose of the drug. So if this is not done, then the patient will be at risk. Then we have to monitor for different side effects, which we shall see. The drowsiness, the ataxia, the bone marrow blood dyscrasias, and all that. So here I've summarized for you the anti-epileptic drugs. Please take your time, because your pharmacist, you're supposed to know the mechanisms of action, okay? I can't explain this because of time, but in summary, there are drugs that block the sodium channel, drugs that block the calcium channel, drugs that block glutamate receptors, and drugs that either potentiate levels of GABA, and drugs that increase levels of GABA, or drugs that reduce the storage of glutamate, which is a neurotransmitter that is excitatory. So take note of the excitatory. What causes excitation is either opening sodium channels or calcium channels, which we have 2 types of calcium channels. There are drugs that block the T-type calcium channels like ethosuximide, and drugs that block the alpha-2 delta calcium channels like yes, drugs that block the alpha-2 GABA, the alpha-2 delta calcium channels like pregabalin and gabapentin. So you'll take your time through this. I didn't want us to go beyond 7, and we are almost getting there. So according to the UCG, the drug of choice for absence seizure can be valproate or ethosuximide. And then generally drugs used in seizures include phenobarbital, carbamazepine, or valproate. In status epilepticus, we know that benzodiazepines are the drug of choice. Actually, evidence has shown that lorazepam is the best benzodiazepine for seizures because it has a more prolonged CNS action. However, diazepam can also be given 10 milligrams IV and repeated every 10 minutes. That's why if someone has not responded to more than 2 doses, again, that is a status epilepticus, okay? Phenobarbital, 10 to 15, or phenytoin, 15 to 18. Now, I have to mention that when these drugs are given IV, the most common side effects that you have to know, for example, if diazepam is given orally and IV, the side effects are different, the same with phenobarbital. The most important side effects are hypotension, respiratory depression, and sometimes cardiac problems. Please take note of that. That should be your rubric. So I've listed for you here the different drugs, carbamazepine, the dose, phenobarbital, the dose. But most importantly, you have to take note of how long does it take for the drug to reach steady state. For carbamazepine, 8 days. For phenobarb, about 2 weeks. And then take note of the side effects, bone marrow suppression, the autoinduction, the blurry vision, ataxia, nausea, and then for phenobarb, the drowsiness, lethargy. Phenobarbital is associated with a lot of hyperactivity and irritability in children. However, we also know that phenobarbital intravenous is the drug of choice for the neonatal seizures. And then I've also put for you phenytoin, which we know is a drug that actually undergoes saturation kinetics. And it's also a drug that normally they give by loading dose. You can read more about that. And then the major side effects, including inducing CYP 450. Okay. So these are some of the questions that I want you guys to ask yourselves. What is the drug of choice for neonatal seizures? We've already answered that as phenobarbital. Why is diazepam avoided in neonatal seizures? It's because actually it has a long CNS action that causes serious sedation. And then some of the preservatives can also cause bad side effects like canicterus with benzyl benzoate. Cognitive impairment, including phenytoin. When a woman is going to get pregnant, they should stop taking valproate at least 3 months before they get pregnant. So most of these antiepileptic drugs are dangerous in pregnant, except lamotrigine, which is a bit safer, and to some extent levetiracetam. Then the phenytoin on the fetus, causing cleft lip and cleft palate. These are malformations. And then saturation kinetics of phenytoin. And I already said that when you are studying a drug, you have to know the other indications. What else is carbamazepine used for? Did you know it's the drug of choice for trigeminal neuralgia? And we also use it in neuropathic pain and bipolar disorders. What about valproate? Can it be used in migraine headaches? What about phenobarbital? Can it be used as a sedative hypnotic? The monitoring parameters, and then the best drugs for epilepsy in pregnancy. And then I've put for you some summaries. I think I would like to stop there because of time. Because of time, I would like to stop there, and I would like to hand over to the moderator. Before that, I don't know if Dr. Nicholas is still on. I would like him to give 1 or 2 comments, including this question that someone has asked about epilepsy and the new moon. Of course, there are always triggers in epilepsy, including seasonal changes. for different people, changes in season and highlight increased firing in the CNS, which can actually cause a seizure. I'll hand over back to the moderator. Then I wanted to have about, because it's 6:53, I wanted to have about a few minutes to discuss the case for people who have any insights into this case, and then we end it. And if anyone has a burning question, they can still go through the moderator to address it. Otherwise, thank you so much for listening. Back to Dr. Arinda.
Thank you, Dr. Chans, for that very wonderful session. A lot of thankful comments are running around the chat. We are grateful as the intern pharmacists of Uganda, and I hope at least every one of us have picked more than 5 points in this presentation. Dr. Muchibi, I'm unable to authorize the microphone for him. The rights are the pharmacy house, and I think by now they have closed. I don't know whether he is okay with typing for us. The comments, maybe you can answer a question or two.
Okay. Dr. Muchibi, you can type your comments. I wanted you to speak, but unfortunately the time has gone. I also have Dr. Musinguzi, who is also a psychiatrist. They are on. So if they have anything to type or respond.
I can look for them briefly and see whether I can open their mic.
Okay, so if Dr. Muchibi is there, he can go on with that. So in the meantime, yes, Kiseka Enoch raised the hand. I don't know if you want to speak or you want to go through the moderator. I wanted us to discuss this case a little, but you can go on. Back to you, moderator. Thank you.
Dr. Sega will first help us with the rights to Dr. Muchibi so that he can pass on the comment, then we can continue to the case.
Okay, so other members, please type. As you can see, giving rights to speak is not easy. So please type your question. We shall address it.
Meanwhile, Doctor, can we attend to some of the questions in the chat?
Yes, we can.
So the first question is from Tikol Hope Nancy. She's asking what are the different types of status epilepticus?
Yeah, so we normally have what we call convulsive and non-convulsive status epilepticus. I've already talked about what convulsive is and what non-convulsive is. So those are the two types: convulsive status epilepticus and then non-convulsive status epilepticus. So the non-convulsive, we have a lot of distortion in someone's state of mind. You'll not really see someone convulsing, but in that time, the seizure is going on uninterrupted. Then the convulsive is where we see the continuous uninterrupted seizures, as we mentioned, lasting more than 30 minutes or lasting more than 5 minutes if they are continuous uninterrupted, or not responding to two or more doses of diazepam. Thank you.
Thank you, Dr. Sacha was talking about the drug of choice in epilepsy. I think you answered that. Lamotrigine or levetiracetam to some extent. Then Francis is saying that you comment on the use of folic acid.
Yes. So folic acid, drugs like phenytoin and carbamazepine, of course, it's more prevalent with phenytoin. They normally cause what we call megaloblastic anemia as a side effect. So the red blood cells are actually big, which will lead to elevated MCV. Sometimes they'll ask you what are some of the parameters you have to monitor. So in those cases, you'll see some of these patients oftentimes on folic acid. Okay. However, we have to be precautious. Even though studies have not shown a lot of antagonism, again, too much folic acid can interfere with the efficacy of phenytoin. but 5 milligrams daily can be okay. Okay, so that's where folic acid comes in. Thank you.
Dr. Mchiba, I request that you raise your hand so that we can give you the right. Then another question. Martin is asking the current research's opinion about the shizas being common in the season of when you are getting the new moon.
Yes, I think I commented on that, and I'd wanted my psychiatrist, Dr. Mchibi, to comment on that. But for some reason, I don't know if he's still on. You know, it has been a long session, so I really understand. We had over 180 people, now we are 140. So you can understand that. I don't know if he's still on. And I also see Sega raising a hand. Maybe he can.
I'm trying to find Dr. Mchibi on call, but I can't get to see.
Okay, so if he's not on, I suggest that we summarize this webinar. And I don't know, unfortunately, people can't speak, so it is challenging. Perhaps I'll leave this case to you, or people can type their answers. But when you look at this case, I have a 35-year-old who is showing clear symptoms of disorientation and all that for 4 years. So this means this person is a non-schizophrenic patient. The person has very poor appetite and has been drinking alcohol. This clearly shows you this person has been drinking alcohol for 15 years. So that means that the alcohol is causing a lot of issues. And that is why when I ask you what baseline investigations are important in this patient, please you don't forget to look at the blood glucose, to look at if someone is having, of course, hypoglycemia, the MCV, which is normally known to be elevated in people who are alcohol abusers, and the GGT, okay, which is a liver enzyme that shows inflammation. In addition to other things like a CBC, which can be an infection can trigger, and also it helps us to look at the other blood parameters. And of course, we know, of course, here we have clear history, so we should not also subject the patient to a lot of unnecessary tests. We can do, we can screen the patient for an infection because it can trigger. So the patient undresses, runs away, all this history, the speech is disorganized, and then you have to take note of the 3 days ago since the last drink. So this one is showing you that this person is having a very severe alcohol withdrawal state. And this person is having delirium tremens. What are the symptoms of delirium tremens? I told you before that many times we know these things, but when they give you a case, you can't answer. Delirium tremens comes with confusion, disorientation, agitation, abnormal blood pressure, hyperthermia, diaphoresis, which we are seeing in this patient. So this person has delirium tremens. Most of the times, if you want to answer some of these cases better, first look at the case and analyze it before even you go to the management. For example, if you are to manage this patient, what is important? The patient has delirium tremens. This patient needs diazepam, high doses, okay? So the patient now you know is being given 5 milligrams. That is definitely ineffective. The patient should be given maybe 30 milligrams twice a day perhaps, or 30 milligrams, or 10 milligrams, repeat 10 minutes. You saw the maximum dose is up to 200. If it's more than that in 3 hours, then someone has refractory delirium tremens, okay? Then the other thing is what we saw in treatment of alcohol use disorder, the dextrose, the thiamine. We also saw that in delirium tremens, we have to give thiamine 3 times daily, 3 to 5 days, for 3 to 5 days. And in alcohol use disorder, it has to be continued for 2 weeks. And then this patient has schizophrenia clearly, not only alcohol-induced, but also the chronic schizophrenia. So which drugs are we going to give this patient? Okay, you can choose any, you can choose the risperidone is okay, you can choose any of the antipsychotics. And then if they tell you to draft a care plan, you have to look at the healthcare problem of this patient. If someone asks you, what are the differentials for this patient? What do you think can cause this? Sometimes, for example, if someone is diabetic and they have diabetic ketoacidosis, if someone has organic delirium or delirium from other causes can also cause this. So you have to look at the drug, the healthcare problem and address each of them, okay? And then, why would this patient be on carbamazepine? And if it is alloperidol, what dose do we give? What route of administration do we recommend? Okay, so those are just my points that I can give you about this patient. You can discuss more among yourselves. Otherwise, I would like to end it at that. Thank you for the opportunity to give, but I had to spare time. Dr. Sega has been on me for over 4 weeks, but I'm glad that I finally made it. I've also been trying to present my PhD work, proposal at MUST and all that. So thank you for the opportunity. Thank you, Dr. Arinda, for the moderation, and I hope members have benefited. Back to Dr. Arinda.
Well, thank you so much, Dr. Dan. Dr. Dan. I think you will share with me the slides, or you share with us so that we can go through them over and over again in our preparation. The Sega and the team, the president, for preparation of this webinar. And thank you all of us for attending this. I'm going to keep reminding Chans to share the slides with us so that I can drop, so that we'll be reading through them in our preparations. I think we can end it here. Thank you, Doctor. Thank you, team. Have a blessed evening and night.
All right, good evening, everyone. I wish you success in your exams. Please, when you're reading these CNS disorders, read all of them. I wish I had time to talk about bipolar because it's closely related to depression. There was no time. I wish I had time to talk about anesthetics. There was no time. So please read all these CNS disorders, and I know if they appear in your exam and even in your daily practice, you'll be fine. Otherwise, I wish everyone a good night.